السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا.
وعليكم السلام ورحمة الله. I think we should go ahead and get started. Assalamu alaikum. Good afternoon, everyone. Ramadan Mubarak al Jamii, and I would like to extend my special congratulations on the first half of Ramadan. And inshallah, it will be more better days to come in the coming 2 weeks. And of course, we thank you for joining us into this educational activity about pulmonary hypertension that's intended to outreach majority of practitioners, primary care, subspecialties, or the people who are not very familiar and treating pulmonary hypertension, in order to open the channels for some more knowledge, maybe for sharing knowledge, and opening channels of communication, referral if you wish. And we appreciate the sponsor and support of Janssen for this educational activity. The team that is conducting the activity, we are all physicians at King Fahd Medical City from pulmonary background, cardiology background, and pediatric cardiology background. And all of us are practicing pulmonary hypertension for many years now, and we have subspecialty in our area. So we hope that our presence will be adding to your knowledge about PH, and we are putting ourselves we are putting ourselves in the front here for you to get to know us, to communicate with us. And if you have any questions, directly communicate with us, or refer a patient that requires some follow-up or workup or diagnosis and treatment. We will try to be time sensitive. يعني Ramadan Mubarak, alhamdulillah. اليوم الجمعة we finished prayer, and inshallah before Salat al-Asr we will be completed our programs, and it will be hands-on mainly, or at least practical, and hopefully we'll be able to answer all your questions. My role is to talk about what do we really need to know about pulmonary hypertension. It is a field of study that now there are some fellowships for it. Some people go for subspecialty training in it, and it's becoming a wide specialty. But we can try to summarize and highlight the important points any physician, any medical practitioner, any ancillary services that are working in the field to get to know about it. Pulmonary hypertension now in Saudi Arabia at least is becoming very common diagnosis. We have many centers that treat the disease, and it's not uncommon to encounter a patient with pulmonary hypertension either in your clinics, in the emergency room, or in admission to the hospital for whatever reasons, anesthesia, post-operative, ICU, and medical ward. So it is nice to be able to understand the basics and see what we can do about it. The picture that you're looking at now is a representation of the pulmonary artery. It's very, very thin walled, easy, that is expandable, can accommodate the cardiac output once it's getting to be recruited. The lung around it is filled with air, and of course this is conducive of having low pressures in the right-sided system, unlike the systemic pressures. The pulmonary artery pressure is usually low, and the resistance is extremely low because of the capability to expand, open new capillaries, and accommodate the cardiac output. And if you see from invasive measurement, the difference in the the difference in the pressures from the systemic, it was all up high in the left side of the heart, and as you go into the pulmonary circulations, the pressure becomes significantly low, and this is normal. This is where the flow to the lung is easy, is smooth. The right ventricle, dealing with this low system, is different than the left ventricle. The right ventricle is again thin-walled, does not really need to have too much muscles to push the blood all the way down to a low resistance system. A little bit of movement, even sometimes from the septum, can propel the blood into the lung, where the gas exchange will take place. This is extremely essential because eventually, all the blood will go to the lung, where it will be picking up oxygen and getting rid of carbon dioxide. This is a picture of a normal echo, and this is a very nice picture showing you the exact movement of the right side. It's different than the left side. You rely on a longitudinal movement to push the blood into the lung, and the contribution of the septum definitely is there. Sometimes if you are at rest, the right ventricle contribution to the pushing of the blood to the right side is really minimal. Some people might live even without right ventricle, but of course, as the exercise, as the load on the right side becomes higher, you need a little bit of kick from the right side to propel blood into the lung. So as simple as it is, we are dealing with a pulmonary hypertension. Anytime this pulmonary pressure increases above 20 millimeter mercury in the presence of like increase in the resistance more than 2 Woods unit, that will fulfill the definition of pulmonary hypertension. You know, it's unlike the systemic hypertension. Of course, the numbers are different, and during the talk you will appreciate the differences between a system that has tone issue where the the muscles will contract and relax, and remodeling issue where the blood vessel itself will be completely remodeled. Now, just as a pressure, like definition. So by definition, it is a pressure. Any disease that is associated with increase in this pressure will fulfill the pulmonary hypertension. So pulmonary hypertension is not a disease state by itself. It is a hemodynamic definition that is joined by many diseases. And this is what we are going to try to explain to you. This is a pulmonary artery of a patient who unfortunately died with pulmonary hypertension. And this is at autopsy. And you can tell the difference between this pulmonary artery and the artery that you saw earlier. The artery here is really filled with cells. It's almost obliterated. And this is a classical pathological change. It's called the plexiform lesion. That is the hallmark of pulmonary hypertension. Imagine this is happening into all the pulmonary circulation. So you can tell that the blood is not really propelling nicely. The pressures are going to get higher. The resistance against the movement of the blood to the lung is becoming worse. And consequently, the disease will present itself. This is another like biopsy, not autopsy. The patient's still alive, and there went some surgical lung biopsy, and look into the middle of the picture. There is supposedly a pulmonary artery, and of course this is something that is not that what we saw earlier, because this is almost obliterated. There's plenty of infiltrates around the pulmonary vessel, and that can explain the pathobiology of this. Consequently, the right ventricle has to work harder to propel blood, and it's similar to when we exercise and start building muscles. Normally, the resistance is low. The right ventricle easily can propel the blood to the lung. Now, the right ventricle has to exert some work. And over a little bit of chronicity, the muscle will start to be hypertrophied, and definitely the geometry of the heart, the right side of the heart does not look the same as the normal right ventricle that I showed you earlier. And this is 2 echocardiograms showing on the left side. Of course, the right side is to the left of the screen, and showing you on the left a normal right ventricle. It's very smooth, very small, and the right side, on the contrary, it is dilated. There is difficulty of pushing the blood all the way to the circulation, and a little bit left over volume overload on the right side. And this will lead to consequences of the disease that we are dealing with. The history of this disease is relatively new. Probably if we have senior physicians with us on the group, they might have heard about the term pulmonary hypertension during their studies. The disease is really relatively new, and the treatment of the disease did not become available until about 25 years ago, when start to develop medications for it. Like first report in the literature was in 1891. I was told it was a few years before, but it's around that time when pathologists noticed that people coming with heart failure, and they don't look like the heart failure people are familiar with, the left-sided failure, younger, somehow the picture is different. And when they did the autopsy and the pathology of the blood vessels, they called it pulmonary vascular sclerosis as a pathological description of the changes that took place in the pulmonary circulation. That was, about 130 years ago or so. Now, the issue was very slow. People did not pay much attention for it. It was a few cases that were, paid attention to until the 50s. And at that time, probably before that time, there was a group in the US who were working on development and, mastering the technique of the pulmonary catheterization, being able to do CATs through catheters and measuring direct pressures into the heart. And this group, they noticed that there is cases that they come and they manage to get their hemodynamics by doing the right heart catheterization of WISH. At that time, it was called the primary pulmonary hypertension. All these terminologies has changed, and we will tell you the new terminology. They did case reports of 3 cases where they had the pulmonary hypertension at the time, and they noticed their hemodynamics, and they showed pictures of the heart of the people who died. and images similar to what I showed you, but it's uncolored back then in the 50s. After that, the same group, they managed to collect about 39 cases, and they put them in a publication in 1954. And this is what they said back then. We're talking about 60 years or more ago. They called it primary pulmonary hypertension runs a malignant course characterized by right heart failure, not infrequently terminating in sudden death. And this is their experience back then. It affects young people. It is aggressive disease and presents with heart failure, and usually it leads to death. Also, in that article, they were saying that the diagnosis should be made not only by a process of elimination. Sometimes the patient comes to you, you start ruling out diseases, but now the availability of the hemodynamic invasive definition and invasive diagnosis, they are calling that we should be actively looking for this disease, since we are the capability and the nature of the disease now becoming very aggressive, and people knew about it. And this is something that is considered historically very important, because at that time this is the first time people have heard about it. This is a historical view of what has happened between then and now. Like very minor activities, like little interest in the disease because it was present in case reports. At most, people might mention it in the books of medical books, but there was no treatment available, no very well characterization of the cases, and the diagnostic techniques were not very readily available up until lately in the 70s or 80s of this like last decade. And people were starting showing interest, and there is like a national NIH had started a registry. They studied the disease, and they managed to collect back in the 80s 187 cases in the US, and they were just having multi-center, and they just characterized their diseases. They noticed that having pulmonary hypertension is a bad news. People are dead. The 5-year mortality rate between 1, 3, and 5-year mortality rate, 68%, 48%, and 34%. These patients at that time, they were just observed, and it was very shocking news that you have a young person in their 30s, and they are 2/3 of them are dead in 5 years because of their disease. Nothing happened, and people were just paying attention and working on it. In 1996, the first agent to treat this disease became available. After that, there was booming in the interest of the disease. Lots of people were working on it and trying to, come up with newer medications, understanding the disease better. And there was a World Health Organization meetings that were planned to be conducted in 1998 every 5 years. There was one in 98, there was one in 2003, there was one in 2008, there's one in 2013, and the last one, which was the 6th one, was in 2018. The next one's supposed to be 2023, but they pushed it 1 year. So next year, there will be another meeting for this World Symposium on Pulmonary Hypertension to review all the evidence that has been published in the previous 5 years, try to see if there's any new things, any new science that mandates changes in the guidelines. And the current guidelines is based on the meeting that took place in 2018. From the beginning, they realized that this pulmonary hypertension, it's not one disease. It has multiple groups of the diseases, and they classified them into 5 major groups. We call them WHO classification. Group 1 is the group that we are interested in. They called it primary pulmonary hypertension back then. Now we call it pulmonary arterial hypertension, and it has subcategories. I'll mention them later. There is pulmonary venous hypertension that is related to the left side of the heart. Pulmonary hypertension associated with lung disease and hypoxia. Pulmonary hypertension due to recurrent pulmonary emboli. And the 5th group is miscellaneous, not very well characterized disease states that can be grouped together in a special classification. These patients in general, they do share a lot of common clinical presentation. Some of them, they have classical pathological findings, and if it's not classical, it really leads to changes in the pulmonary vessels to the point where that can explain what's going on. The hemodynamic characteristics, if you put them into the cath lab, you will see similar hemodynamic as per the definition. And now, currently, we approach pulmonary arterial hypertension as a one disease, one entity, although they have different diseases leading to the common final pathway of elevation in the pressure in terms of the treatment. And when we look at the studies that the treatment of these patients, we look them as one group. The latest grouping of the disease as per the guidelines is the group 1, which is pulmonary arterial hypertension. It can be idiopathic, and there is heritable, there is associated with the drugs and toxins. These are the classical prototypes. Some heritability is there. It's not that common. We have patients in our clinics who have the mother and the daughter affected, definitely. France has probably like more number of cases. In the US, they have 200 families that are well known to have multiple pulmonary hypertension like disease in different grandmother, mother, and daughter. The ones that are associated with that, these are connective tissue diseases, HIV, liver diseases, congenital heart diseases, that is not heart failure that leads to increase in the shunt. Some places like Egypt, like Brazil, where schistosomiasis is really common, it can be associated with it. As you can see, like a rheumatologist, like ID physician, like GI physician, maybe cardiologist, like all of these people are somehow, they can be involved in the diagnosis of pulmonary hypertension, and they tend to see cases in their clinics that maybe they pay attention to them, maybe not, but these are common diseases that we see in our practices, internal medicine, family medicine, subspecialty medicines, and all of them, they share the same diagnosis of pulmonary arterial hypertension. Not of course, everyone with these diagnoses will develop it, but they are prone to developing it. Some other groups, that persistent PH of the newborn, we will have a little bit of pediatric like talk a little bit about these cases maybe, but some of the newborns, they fail to open the circulation in their right side, and they will persist to have pulmonary hypertension that time. And there is a new entity, or somewhat different entity. It's called pulmonary veno-occlusive disease, that is has some genetic background and a little bit different, but it's grouped together because they present the same. They have the same hemodynamics. Unfortunately, they tend not to do very well, and they require lung transplantation. The group 2, we talked about heart failure. If you want to remember it, any cardiac disease or any mediastinal disease that elevate the venous pressures can be associated with this. And this is a very common group. Classically and traditionally, we say the most common cause of pulmonary hypertension or right-sided failure is left-sided failure. This is still holds true. Heart diseases are common in our community. People are getting older. Some studies referred about 10% of people who are above 60, they are probably going to have pulmonary hypertension. Most of them are secondary to left heart disease. Now, if you are a pulmonologist or you're dealing with a lot of lung diseases, the lung diseases are probably more common than idiopathic or pulmonary arterial hypertension. And we tend to see patients who have in the stage COPD, in the stage like ILD. Sometimes they have hypercapnia from whatever reasons. And all of these can be associated with pulmonary hypertension that is existing. I mean, they share the same definition, yet it's a little different disease. It's a different group of the disease. Group 4 is of interest because I'll talk a little bit about it later on, because we have, for some reason, we have more common or more prevalence of pulmonary embolism in the region. And some of these patients, they continue to have pulmonary hypertension because of the recurrence of their PEs and the clots, whether it is the underlying genetics, whether it is the compliance with the anticoagulation. But definitely in our clinics, we tend to see probably as much pulmonary hypertension due to chronic thromboemboli as the others, the pulmonary arterial hypertension. Group 5 is we group things that are not very classical in it, but they are all associated with pulmonary hypertension, like systemic disorders, metabolic disorders. Sickle cell disease, for example, is included in these hematological disorders. We don't have much thalassemia in Saudi Arabia, but thalassemic disorders are very commonly associated with pulmonary hypertension. They have a little bit different approach. The treatment is not very well established for them, similar to the other groups. That's why they put them in this group of 5, because probably more work is needed to be done on them. So again, all of these diseases that we mentioned, they share some common hemodynamic definition. So to call it pulmonary hypertension, the pressures above 20 in the pulmonary circulation, that is measured by right heart cath. These numbers are hemodynamic numbers, not estimated numbers by an echo. I think the next talk will clarify this point clearly. This is a hemodynamic definition. The precapillary, the ones that we are very much interested in, is that you don't have a heart failure leading to this disease state. So the pulmonary arterial wedge pressure should be low, meaning that they don't have any evidence of left heart disease. And this group can be the idiopathic one, the PAH one. It can be the chronic thromboembolic one, and it can be the ones that are associated with lung diseases. So again, you have to really clinically tell, is this the idiopathic or because of the lung disease? If you look into their hemodynamics, they might be the same. Now, heart failure can be associated with pulmonary hypertension, and we don't want to complicate the issue. Some of them are pure, they're just straightforward. Elevation in the left-sided pressure will be very equally elevation in the right-sided pressure, but sometimes with the chronicity, there will be changes in the pulmonary circulation itself that will lead to increase in the pulmonary vascular resistance above the normal, and then these patients, it looks like they might have a mixed or combined picture that we usually don't recommend the treatment for them. They are different group, and for the sake of discussion, we will try to avoid talking about this group for now. Recently, they introduced the exercise pulmonary hypertension. It was there before, but this is people who are completely normal at rest, but when they exercise, they start having somewhat a disproportionate ability of the pulmonary circulation to tolerate the increase in the cardiac output. And it's just during exercise, they start having symptoms. Once they are at rest, everything cools down. If you do the right heart cath for them, they will become normal. You will be difficult to tell them. So to diagnose them, you'll have to exercise them while they are doing the right heart cath. Again, this is still not being detected much. Probably the number of cases are small, but it is there. This is the hemodynamic classification that I mentioned. We are interested in the precapillary, and we have to be a little bit careful about in the precapillary, are we dealing with the pulmonary arterial hypertension, the group 1 or group 3? And I said the PEs, and they have a special case. So these are just a very nice picture showing the 5 groups of the disease. The idiopathic, the heritable one, is the first one that will be classically changing. Group 2, that has something to do with the heart disease. Group 3 has something to do with the lung disease, and the group 4 has something to do with the recurrent thromboemboli. And the 5th group is somewhat not very well characterized. If you notice, very common to have group 2, somewhat common to have group 3, and rare to have pulmonary arterial hypertension. So the pulmonary arterial hypertension that we are talking about is still considered a rare disease, but with subspecialization, with the clinics that they are dealing with these cases, we tend to see good number of them. The institutions where there is PH centers, like almost everyone in the emergency room, in the other clinics, in the referring clinics, and in the ORs even, they are familiar with these cases because they have a reference clinics that they come to, and they require a lot of medical attention as well. And these patients, they just don't have pulmonary hypertension. Sometimes they require surgery, sometimes they develop infections, sometimes they have to come to the ICU for a reason or another, and they will be exposed to different specialties. Why do this happen? Sometimes this is a question that some people, patients themselves, unfortunately, classically, the patient is young. It affects females more than males. And in average, our cohort here is in their 30s. So imagine somebody who's in their 30s. We definitely have patients in their teens and the 20s, but they are classically having supposedly healthy, starting their life, finishing school, starting family, or shortly after, and now they are having a disease that will probably, put them to be dead within 5 years. This is something that is shocking, unusual. So people ask, why me? Why did I have this? Studies were looking into the pathobiology of this disease, and genetics is one of them. I mentioned the heritable part, and they identified a few genes that can be responsible for the development of this disease. B and BR2, you don't have to worry about it unless you are interested in the genetics part. But this is important for the programmed cell death. Failure of the system will keep the cells growing out of control, and they just don't die when they are supposed to die. That's why there is so many cells in the endothelium that will lead to the proliferation of the disease. Another genetic factor that I mentioned, this is the PVOD. It was described in France, and now we do test for this disease. This is a little bit unique form of pulmonary hypertension that is associated with like dilatation of the capillaries. It's similar to the grape if you look into it in some aspect. And the problem is in their venules and in their post capillaries, and it will lead to pulmonary arterial hypertension definition. But when you treat them, they start having pulmonary edema. Now, it's a little different group. We have few patients. Some of them unfortunately died. Some of them has already been successfully transplanted, and they are doing okay. Some people look into what happens. It's the progenitor cells from the bone marrow might replace the endothelial cells, and these somehow they lose their like control, similar to the cancer cells, where they will continue to proliferate and occlude the circulation. We discovered that endothelin, it's one of the molecules that is really toxic, really vasoconstrictive. It can lead to changes in the circulation, the pulmonary circulation in particular, and it was the expression of this endothelin receptors is higher in patients with pulmonary hypertension, and actually now we treat patients by blocking this. Rheumatological diseases, if you see, this is a very nice diagram showing that connective tissue diseases, we mentioned they are common to be associated with pulmonary hypertension, scleroderma in particular, and you see the walls of the pulmonary artery are filled with inflammatory cells that are recruited, you know, whether secondary to an insult, the patient have the tendency to develop the disease with some disease activity, there will be more cells, maybe more fibrosis, and consequently the changes that we see. In left heart disease, patients will have elevation in the pressures, and this will be transmitted in a backward fashion towards the right side. As the pressures inside the left heart increases, it will be transmitted to the right side, and passively the increase in the circulation. And in lung diseases, of course, at one stage, maybe with the hypoxia, with the damage in the lung, there will be a reversible hypoxic response. You know, hypoxia will lead to constriction of the pulmonary circulation. At certain points, it might be reversible. We see that sometimes in patients who have acute illness. If you do CAT for them or echo, they might start having a little bit elevation in their pressure, but it will resolve as the hypoxia goes away. The circulation will restore and everything goes back to normal. But some of them, if the disease persists, or they are having a specific phenotype that leads to them to develop this persistent of the pulmonary hypertension, they will develop pulmonary hypertension that's usually out of proportional of the initial pulmonary insult, and it will be associated with the pulmonary hypertension as we saw. So far, we know this is not a tone disease. This is a disease that inherently affects the pulmonary circulation in a pathological way. There will be occlusion, fibrosis, inflammation, and consequently, what we have talked about, this will lead to progressive decline in the right-sided function of the heart. Early on, there will be muscles, there will be ability of the heart to deal with it, trying to maintain the cardiac output despite increase in the pressure against resistance. The PVR will continue to go up until a point where the heart will fail to cope with the increase in the demand. And then the patient will start to have symptoms. So the disease usually starts way before the patient has symptoms. There is a period of time when the symptoms were not very classical. We'll talk about them in a minute. And this might even delay the diagnosis further up until the point where they might be coming with decompensated right heart failure. This is a very unfortunate phenomena. We are seeing less and less of it, but unfortunately, till today, we are seeing cases. About a month ago, we had a patient in the emergency room with decompensated right heart failure because of severe pulmonary hypertension. We recently got a referral of a pregnant woman who's advanced the pregnancy, who have severe pulmonary hypertension, and she is not very well, let's say, diagnosed and managed. And so these cases do exist. And again, if you look into the course of the disease, at one point in their life, they must have some symptoms, whether they translated the symptoms into a visit to the doctor or the doctors failed to recognize that these symptoms might be secondarily to a right heart failure or pulmonary hypertension that requires some attention. Symptoms are not specific. So these, if you are primary care physicians, I'm sure you see patients who are coming with a little bit of shortness of breath. This is an extremely common representation. Shortness of breath is very common. The vast majority of people who are short of breath don't have pulmonary hypertension. There is much more commoner diseases that can lead to dyspnea than pulmonary hypertension. That's why people will start thinking of what's common, and this is rightfully so. And we don't want to be thinking of pulmonary hypertension in any patient who comes in with dyspnea, but sometimes they fail to improve. If you assume they are having asthma, you treat them as asthma, they did not get better, or they have some other features that are not consistent with asthma. If you think they are having a bronchitis or pneumonia, and you treat them and they are not doing better, there should be something else going on. So some of these cases, they do require that you have to follow them up and see exactly what's going on. Now, some people, they might present late, and you look at the patient, They are really having very advanced symptoms, right heart failure symptomatology. They have edema. Some of them, I have a patient once, she has hoarseness of voice because of the encroachment of the pulmonary circulation into the recurrent laryngeal nerve. And sometimes they really come in very, very syncopal. Sometimes they cannot really stand up and they are bedbound or wheelchair bound. All of these symptoms depending on the stage of the disease. And when you examine them, supposedly they can be normal early on. But unfortunately, we are seeing patients in a little bit advanced where you will listen to them, you might start seeing them having accentuated heart sounds. The P2 classically is elevated. Sometimes you might hear a murmur. Sometimes you might feel that there is a distant heart sound if there is a pericardial effusion. And if you look into them in general, their level of oxygenation a lot of time is normal, but sometimes they cannot really tolerate any exercise. So you look at them, they are saturating well. You ask them to walk a little bit, and they really cannot do it, or they start huffing and puffing, and then they will start becoming cold extremities and all the features of inability of the heart to meet the cardiac output demand from that little exercise. Sometimes you might find features that is related to the underlying disease. And you have a patient who have pulmonary hypertension, they come to you with like liver failure, picture of a liver failure. Maybe they are jaundice, maybe they have all the cutaneous changes of liver disease. Connective tissue disease, they might have SLE is common. You can have malar rash. You might have joint issues, depending on the underlying cause of their disease. They can come early, they can come late, and we adopt the heart failure New York Heart Classification to tell functionally how well they do. Class 1, they really have symptoms upon significant exertion, versus class 4, who they are really bedbound, they can do nothing, and they are very symptomatic, even sometimes at rest. And the class 2 in between, a lot of times we see them in class 2, 3, sometimes 4, but 3 is very common, that the patients either by the time they get referred and the time we see them, they have progressed from early symptoms to late symptoms. And if you ask the patients themselves, they say, wallahi, like 6 months ago, I was able to do this. Now I am unable to do this particular activity, or, keeping up with daily living. So this is a progressive according to the disease. Of course, if there is no treatment, things are going to go progress, and sometimes they really is bad. We mentioned that having pulmonary hypertension is bad news. These figures that you look at is from the registry from before, the red side. We are treating these patients nowadays, and still our survival is not where we like it. This is from the reVEal registry, showing that still, even with therapy, the outcome is not the best. That's why there should continue to be work to improve on our outcomes. But definitely patients are doing better when they get diagnosed earlier. Not all of these diseases share the same prognosis, let's say. People who have congenital heart disease associated with pulmonary hypertension, they tend to do the best. But look into the people who have connective tissue disease or HIV-related pulmonary hypertension, they tend to be the worst. And the idiopathic, the pulmonary arterial part, they are in between. Some of these, the heritable, are probably the worst. Connective tissue disease, I mentioned the scleroderma. These are very sick group of patients, and their outcome is not the same as patients who have it. We have known this since the beginning of working with pulmonary hypertension, that the later the presentation of the patient, the worse the prognosis. If they come in functional classes early, 1 and 2, they tend to do well. They live nicely. Their mortality rate is not as bad. But if they present at later stages, functional class 4, they are dead in no time, really. The probability of survival becomes significantly less, because the disease has really advanced to the point where, there is probably no return, and the ultimate treatment, if they are lucky, that they will get lung heart transplant, and that's the only option they have at that time. Medication effect might become less strong, and the patients will be really struggling. And also, we knew that there is a delay in the process of diagnosing this disease because of all what I mentioned. Non-specific symptoms, maybe the experience is not there, maybe the subspecialty nature of the disease is making it a little bit more difficult to pick up on. This is from the the NIH registry from the US. On average, it takes about 2 years to diagnose a patient from presentation until establishing the diagnosis. This is in the 80s. So this is when there is no treatment. Nobody knew anything about PH. This is more recent, in the 90s or 2000 something, 2009. This is from Australia, small study. But in average, it takes more than 2 years maybe sometimes 4 years to diagnose a patient with PH. They track these patients down. First symptoms was shortness of breath. First medical contact about 12 months after initial symptoms. An average of 5 general practitioners has seen the patient before establishing the diagnosis. 3 specialists, maybe cardiologists, maybe pulmonologists, and they were given at least 2 different diagnoses, alternative diagnoses, until the point where they were referred for a center of excellence where their disease is, properly diagnosed and initiation of therapy. This time is life. This time is function. This time is really, that's why we are doing this. We are doing this, that we are trying to increase the awareness among everyone, general practitioners, subspecialty practitioners, because all of us can see these patients. The idea is don't overdiagnose it, don't overthink of it, but if the patient fits the profile, they have comorbidities that are associated with PH, try to think of it. If the profile is fitting it, try to consider early referral. We are here, King Fahd Medical City is MOH city that can accept anybody is eligible in the kingdom, and with the insurance probably will be able to see even non-insured or non-Saudi people in the our clinics, and it will be easy. We are accessible. I think we have many practitioners working on there. So the idea is suspect. If you are worried, if you don't know, if you're not sure, we are open. You can just refer it, mention in your referral that I'm suspecting pulmonary hypertension, and one of us will be seeing this patient in their clinics. And the hope is to pick them up early and initiate the proper diagnostic and therapeutic approach for them. I mentioned this before. Pulmonary hypertension is a rare disease. Most of the times when you see a patient with pulmonary hypertension, does he have heart disease? Does he have a lung disease? If you rule out these 2 big things, most likely you are dealing with something that will require further assessment. Again, you have to have a right heart cath. You don't have to have right heart capabilities in your place. You just think about it. The patient does not look like having left heart disease at large, does not look like having advanced lung disease, and they have evidence of PH, go ahead and suspect it. Next lecture, we'll talk about the diagnostic workup. We have a special group here with the recurrent pulmonary emboli. These patients, they are unique. When you look into them, they don't have the classical PE changes on the CT scan. Maybe VQ scan is something that's not available in everywhere, but if you look into their VQ scan, there are some areas that they don't have really perfusion, big segment of the lung where the blood is not reaching them. In the bottom picture, you see an angioscope of a patient with pulmonary embolism that is, leading to pulmonary hypertension before and after. Supposedly, this is how the blood vessel should look like. It's open, blood can go through it, and on the left side, that is occluded. No blood is going to get through, and of course, that will lead to increase in the resistance and increase. The treatment of this disease is somewhat unusual. Medications can work to an extent, but primarily it's a surgical treatment that there will be opening of the pulmonary artery, and there will be, just taking out these fibrotic material that will look like this after the removal of the tissues. And of course, patients, a lot of time, they will normalize. So I will summarize that this disease, there is a person with probability or tendency or genetic makeup, some risk factors that they have that will eventually lead to a vascular injury from inflammation, from fibrosis, from endothelial dysfunction, from some other factors that will lead to deposition of the material into their circulation, and consequently they will unfortunately succumb to their disease. I will mention 2 quick cases. This is a young woman, 24-year-old, engaged to be married. She had symptoms even before engagement. It was ignored. Finally, 3 months before her marriage, she started going to doctors because these symptoms are becoming worse. There was no establishment of a diagnosis. Eventually, she goes to a cardiologist, and the cardiologist did an echo, and the echo showed what you look at, severely dilated right side of the heart. And they said, well, this is probably pulmonary hypertension. Go get married, and we will deal with you after you finish your, now you're busy, you're tired, blah, blah, blah. She comes to our emergency room. Her ECG is very bad, showing right ventricular strain. We did the workup for her, and she has severe pulmonary hypertension. She lost about 6 or 7 months of treatment, and she came in with function class 4. Another case, this is a nurse we have in our hospital. This is her employment X-ray. She was having a little bit symptoms. She keeps, nurse in a tertiary care center. She had multiple X-rays for multiple reasons. This is about a year and a half after. This is another X-ray, came to the emergency room. It was ignored, shortness of breath. Nobody paid attention to it. Again, this is another X-ray. Nobody thought of the pulmonary hypertension until one point she was actually working, almost had syncope, and we were called to see her, and her ECG was really horrible. Her echo is severe, significant pulmonary hypertension, and we did the workup for her, and she does have severe pulmonary hypertension. This is just to highlight that these things are not uncommon, rare, but you will see them, and we'll go through our other presentations, and hopefully the picture will become more clear, and your level of engagement and involvement in this disease will become clearer. I will, kindly ask my friend and colleague, Dr. Abdullah, to join our talk for now. He's going to talk to you about the diagnostic algorithm from your perspective. We are doing tertiary care diagnosis for these patients, but your role in establishing the diagnosis is important. And Dr. Abdullah is a cardiologist at King Fahd Medical City. He's an interventionalist, and he is a pulmonary hypertension trained and practicing cardiologist. Dr. Abdullah.
Thank you very much, Dr. Hussam. Assalamu alaikum, Jami'an. Just give me a second to share my. Okay, so my task is to just walk you through the journey of pulmonary hypertension workup. Now, after we heard the initial talk of Dr. Hussam and the signs and symptoms that are usually present and that lead to the suspicion of pulmonary hypertension, what are the diagnostic workups and how do they align together in the patient journey? So my agenda for today is we touch base on echo and its basics, the imaging that are needed for pulmonary hypertension, the laboratory investigations that are required, and finally the the importance of the right heart catheterization as the cornerstone in diagnosing pulmonary hypertension. So when we talk about echo, which is the basic, which is the initial screening modality that are usually done for patients suspected of having pulmonary hypertension. So basically, the echo can be thought of as either one-dimensional imaging, which is something called M-mode, or a two-dimensional imaging, and finally color Doppler. We'll go over that in details. So the basics of echo is basically the echo probe sends or transmits a excuse me, an ultrasound beam into the body, and then different body structures they reflect this beam, and this results in the ultrasound probe reading those reflected ultrasound beams, and through different and complex processes, projects them into a white and black picture in the screen. So based on these things, so we see that if we only send a one-dimensional or one-way ultrasound beams and wait for them to be reflected back, then we usually get something called M-mode, or one-dimensional imaging. And in this case, this is useful for something called TAPSE, if you've heard about that term before, but basically it's just show you a time motion display of the ultrasound wave along a chosen ultrasound line. Now, if we send multiple images and multiple pulses along adjacent lines, then we do get a live image and a moving image like this one. This is not moving, but this is a representation of a two-dimensional imaging. And this one shows you information about the function of the heart, the size of the heart, and also if there is any hypertrophy of the ventricular walls. Eventually, the concept of Doppler, which is basically best approximated by if you're like standing in a street and you hear an ambulance with a loud siren coming towards you. So you can estimate the speed of the ambulance based on the change of frequency of that siren sound. And that's basically the basics of Doppler. So we detect the direction and velocity of moving blood cells within the heart based on the reflected images from the ultrasounds. Of course, if there is laminar flow, the speed of the blood in the heart is usually not very high. But if there is any turbulent flow, like a stenotic or regurgitant valve, then the speed is going to be very high. So we can detect those differences. So we estimate pulmonary hypertension or pulmonary pressure based from something called the TR jet velocity method. This is a complex topic, but to simplify it, we look at if there is any evidence of tricuspid regurgitation in patients suspected of having pulmonary hypertension, and then we try to measure the speed of that jet velocity of the TR, and based on that and through a complex mathematical equation, we can estimate the pressure from the speed, and this gives us an estimation of the pulmonary artery pressure. Usually in echo reports, it's mentioned as RVSP, or right ventricular systolic pressure. And we know that in the absence of pulmonary stenosis, the right ventricular systolic pressure is equal to pulmonary artery systolic pressure. So this is an example of a TR or tricuspid regurgitation jet velocity. And we can see here that the velocity is approximating 2.8, you can see it here, and then the machine does the calculation for you, so it changes this number into pressure, and we get a pressure of 32 millimeter mercury, and we usually add that to the IVC pressure, so you get finally an RVSP pressure of, let's say, 36 or 37 based on how much you have in the IVC pressure. So this is basically the way we estimate pulmonary pressure from echocardiogram. So this method is not without fallacies, and depending on how much gain you put in on the screen and how much, where do you measure exactly it needs a lot of experience to reduce the amount of errors that can be or that can occur with such method. So that's why it is just a screening method. It is not a confirmatory method for the degree of pulmonary hypertension in any patient. So the new guidelines, when it comes to echo, they recommend a wide variety of different imaging and methods and techniques, and they give you references on what to do. So, for example, we look at different views of the heart. So we look at the lung axis, like in the image A. We look at the four-chamber axis, and each one of these, there are certain measures that you have to do, and there are certain cutoffs to help you diagnose any evidence of pulmonary hypertension or RV dysfunction, for that matter. In D, we can see the IVC diameter, and that also corresponds with right-sided volume and pressure overload. Moving on, we can measure pulmonary valve or RVOT acceleration time. We can measure the area of the right ventricle and how much it changes in systole and diastole. We can also measure the TAPC, which we discussed before. It's called the tricuspid annular plane systolic excursion. It's a surrogate of RV function. Same thing with the systolic velocity of the tricuspid annulus. So all of these are probably out of the scope of this of today's lecture, but it just gives you that gives you an idea that echo assessment of the right side of the heart and also the pulmonary pressure is something that is complex and needs a lot of careful attention and making sure that any errors should be minimized to the best we can. And then we measure the RA size and volume. This is basically the tricuspid velocity that we discussed. Then we measure the right atrial pressure. We estimate that from the diameter of the IVC and how much it collapses with breathing. And then we look at finally the presence or absence of pericardial effusion, which is a sign of a bad and severe pulmonary hypertension. So we can see that echo is an excellent screening tool for pulmonary hypertension, as it is non-invasive and it is reproducible, high negative predictive value, and it's cost effective. It gives us an estimation, and again, I highlight the word estimation of RVSP or pulmonary pressure. It estimates the RV size and function, and again, we know that RV function is not easy to measure and estimate compared to the left ventricle just because of its geometry, but echo can give us a good estimation. Echo can screen for any congenital heart disease that may explain the pulmonary hypertension, and also will give you an idea about the left side of the heart, which is a big contributor of the causes of pulmonary hypertension in general. Next, we move on to the ECG. We saw an example of an ECG from Dr. Hassam's case presentation. So basically, common findings are patients usually have sinus tachycardia. They have right axis deviation. We see that from the negative R in lead 1 and the positive in lead 2 and ABF. You also have a peaked sharp P wave in lead 2. If you go to the V1 here, you can see evidence of right ventricular hypertrophy or sometimes right bundle branch block. So those are the findings that you can see with prime or the idiopathic or group 1 pulmonary hypertension. In group 2, you may also have additional features. But these are very worrisome ECG findings for someone with pulmonary hypertension. Next, we go to a chest X-ray, and we've seen examples as well from the previous case, but in general, you see peripheral hypovascularity or pruning of the vessels just because of the severe pulmonary pressure. You can see prominent pulmonary artery sometimes. That's listed in the differential of Heiler fullness, if you may. Some people confuse that with lymph nodes, but usually they are the pulmonary artery that are dilated. You can see them clearly, and in this case here, where the right pulmonary artery is dilated beyond the hilum. And if you take a lateral chest X-ray, you can see the fullness of the RV, which is the anterior chamber, obliterating the line and the or the retrosternal line. Additionally, you can find signs of left heart disease, pulmonary congestion like pulmonary edema, and also findings of lung disease if the cause of the pulmonary hypertension is group 3, like an interstitial lung disease. So X-ray is very important for any patients during their workup of pulmonary hypertension. Next, we usually go for pulmonary function test and arterial blood gases, and again, those help distinguish between different pH groups and also assess comorbidities and the need for supplemental oxygen. And DLCO also determines disease severity as well. So those are, again, important diagnostic tools for the patient journey. We usually go next to a ventilation perfusion lung scan, and the reason is we want to exclude CTEPH, which has a very different treatment algorithm. So basically, a normal perfusion scan can exclude CTEPH with a negative predictive value of 98%. It is important to ensure that you have the both ventilation and perfusion component of the scan, as sometimes, and also you need to review these images with an expert radiographer, as sometimes certain types of pulmonary hypertension can be misleading, as more novice radiographer can read them as CTEPH when in fact they just represent the normal findings of severe pulmonary arterial hypertension. So you really need an expert radiographer to help you read those scans and get the best out of them. After ventilation or VQ scan, we usually ask for a CT chest, and again, we are interested in the lung parenchyma, as well as we're interested in the size of the pulmonary artery, and sometimes if it's gated scan and has a contrast, can tell us about the presence or absence of old pulmonary emboli, and also the presence or absence of cardiac shunting or cardiac abnormalities. So a CT scan, either with or without contrast, is very important in the diagnostic workup. And again, you really need to have an expert radiographer to help you navigate through differential diagnosis of different pulmonary hypertension etiologies. What are the blood tests that we usually ask for when we have someone suspected of having pulmonary hypertension? So CBC is an initial test. again, kidney function. Uric acid has been shown to be correlated with severity of pulmonary hypertension as it reflects the inflammatory state of the body. Liver parameter, especially if we're contemplating starting certain endothelin receptor antagonists. Iron status is very important, and a lot of PH patients are iron deficient, and supplementing them with iron can boost their functional status. A very important blood test that reflects the prognosis is the brain natriuretic peptides or NT-proBNP, whatever is available in your hospital. Those are very important in the initial diagnosis as well as for future follow-up. Of course, if you suspect HIV or hepatitis as cause of group 1 pulmonary hypertension, those should be excluded. And then basic immunology laboratory to rule out connective tissue diseases, things like ANA, rheumatoid factor, and double-stranded DNA, among other, can be ordered as well based on the patient's symptoms and signs. So after this, why do we still need a right heart catheterization? And multiple reasons. One of them is we just saw that echo can be inaccurate in its estimation of the pulmonary artery systolic pressure due to multiple reasons we discussed before. The echo cannot give you an accurate estimation of the pulmonary vascular resistance and cardiac output, and both are needed for the diagnosis and also estimate the prognosis. Echo does not give us a precise measurement of the left-sided filling pressures, which differentiates between pre-capillary and post-capillary pulmonary hypertension. And again, sometimes it's difficult to assess the RV function, so we need the cardiac output to help us with that. So basically, when we do an echo, we go through either internal jugular vein, femoral vein, or now more commonly we do it through the brachial vein, which we think is probably the best because it has low risk of complication. You can quickly achieve hemostasis. Patient can ambulate immediately after the procedure, and it has a very low risk of complication. So what we do is we go through any of these access points, and then we go to the RA through something called a Swan-Ganz catheter. So basically, this is a balloon tip. There is a balloon at the end of the catheter that, when it inflates, helps the catheter to be floating. And then there is a distal pressure monitor, or distal to the balloon. There is a pressure monitor or pressure sensor that allows us to measure pressure in different chambers of the heart. So we start by going into the RA. We take the pressure here, and this is an example of an RA pressure waveform. We go to the RV and we take the pressure, and we can see the pressure waveform is different. And then we go to the pulmonary artery, and again, the pressure waveform is different from that of the RV until we go to the wedge position, which is basically occluding the a certain subsegmental pulmonary artery. So the pressure sensor only sees the pressure in front of it, which is a stack of blood, a column that is extending from the LA, from the left atrium into the wedged balloon. So that's what we call the wedge position, and it gives us an idea about the left-sided filling pressure or the left atrial pressure. So right heart cath is not just a simple procedure. You really need to pay attention to the details and make sure your connection is all secured. There's no bubbles in the lines. The lines are well flushed and connected. The patient should be in a euvolemic state, should not be having any sedation, and should not be having any oxygen at that time, just because oxygen can sometimes change the pulmonary artery pressure if it's given acutely. So there are some certain precautions that we need to pay attention to. There is really rare contraindications for right heart cath. The most common one is right-sided endocarditis, or if there is any suspected mass in the right side. Presence of a mechanical valve is a contraindication for right heart catheterization, but a tissue valve should not be a contraindication. So this table here shows us a different or normal values for different pressures. So in general, we start with the right atrial pressure, and those are the numbers. We go to the pulmonary artery pressure, systolic, and it should never exceed 30. Diastolic, usually around 4 to 12. And this is the mean pulmonary artery pressure, which we use for the diagnosis of pulmonary hypertension. And you can see here the upper limit of normal is 20. Then wedge pressure, the cutoff is 15. So if it's more than 15, then it is likely to be a post-capillary pulmonary hypertension. If it's less than 15, then we call it a pre-capillary pulmonary hypertension. Again, this important distinction because of the different treatment strategies. Cardiac output is usually between 4 and 8 liters per minute. And then we calculate certain parameters based on these numbers. Most importantly is the PVR. And we now know that the PVR cutoff was changed to diagnose pulmonary hypertension from 3 to 2 based on the most recent European guidelines. This is an example of waveforms of patients with pulmonary hypertension, and this is an RA pressure. We can see that the average RA pressure is around 10, which is higher than 5, the upper limit of normal. So we can tell that the RA pressure is elevated. Going on next, we see a RV pressure waveform, and we can see the RV reaches up to 90s, which is severely elevated because a normal patients, the RV pressure should never exceed 30 systolic. This is a PA pressure waveform, and you can see the difference between the RV and the PA waveforms. Again, the PA is up to 90 systolic, diastolic is around 30s, and then the mean is around just above 50. Again, a significant increase from the upper limit of normal, which is 20. After the PA pressure, we go to the wedge position, and in this case, you can see there's some fluctuation with breathing in the wedge pressure, but we take the average, and it's around 14, 15, meaning it's most likely a pre-capillary in nature. Right heart cath allows us to do a shunt assessment if we suspect left to right shunt as a cause of pulmonary hypertension. And I'm not going to go into the details of how we do that, but again, that's an additional thing we do in the right heart cath. So this is a brief summary of the patient journey through the diagnostic workups when they are suspected of having pulmonary hypertension. Finally, cardiac output assessment is, again, part of any right heart catheterization, and it has a very important diagnostic and prognostic implications for the treatment of patients with pulmonary hypertension. Now, with that, I'd like to conclude, and I would like to introduce my dear friend, Dr. Shaya, who is a consultant pulmonologist and pulmonary hypertension specialist and the program director of the internal medicine at Riyadh Second Health Cluster. So he's going to take us through treatment algorithms for patients with pulmonary hypertension. Dr. Shaya, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for all my colleagues who are attending and preparing for this sessions in pulmonary hypertension. Dr. Hussam, Dr. Abdullah, and Dr. Umar, and also thank you for Janssen for sponsoring this events, and thank you for attendees to be attending this lectures. So Ramadan Mubarak wa taqabbal Allah minna minkum salih al-a'mal wa 'ashr mubarakah. So my talk would be about the pulmonary hypertension treatment and management. So it's always, when you talk about pulmonary hypertension, this is always complicated, and also we have to be like, I would try my best to be clear and make things easier for everybody. So before starting and talking about pulmonary hypertension, always we have to keep in our mind some sort of basics. I would like to summarize some slides from the previous lectures. So always we have to keep in mind that there is a 5 group of pulmonary hypertension. Group 1, where there is problem at level of the vessels itself. Group 2, where there's a problem at level of left heart. So there is a problem in the left heart will affect the pulmonary vessels subsequently by backflow pressure. Group 3, where there is parenchymal changes, and this will lead to certain changes at level of the vessels as well, not similar to the group 1. And when we treat group 3 and group 2 itself, it may improve the group 1, it may improve pulmonary hypertension as well. Group 4, where there is a pulmonary artery obstruction, either by the most common cause of group 4, which is chronic thromboembolic pulmonary hypertension, or other groups or other causes that lead to obstruction of pulmonary artery blood flow. Group 5, there is a lot of diseases where the pulmonary hypertension is unclear pathophysiology. It can mimic one of the above 4 groups. We have to keep in our mind the 5 groups, as I mentioned before, and the most common cause of pulmonary hypertension. As again, pulmonary hypertension indicates there is an elevation in the pressure, but pulmonary arterial hypertension is a group 1, meaning there is a problem at level of the vessels. Though the most common cause of pulmonary hypertension is a group 2 and group 3. And when we deal with these 2 groups, we can manage the pulmonary hypertension, which is a second manifestation of these causes. Group 1, which is going to be talked about to treatment in subsequent slides, and is our target in this lecture. Group 4, there is a specific way of treatment. It's a bit similar to the group 1 in terms of pathophysiology to some extent, but the treatment pathway and the causative leading cause of group 4 a bit different, when there's mainly thrombus that need to be extracted to improve the pulmonary blood flow. So the main group and the rare group of all these 5 groups is the pulmonary arterial hypertension, that we have to make sure, as mentioned by Dr. Abdullah, that this group has been diagnosed well, and what we are dealing with of pulmonary hypertension is a group 1 in order to start a specific targeted therapy that we are going to talk about soon. So pulmonary hypertension is an uncommon disease. A limited awareness of pulmonary hypertension can lead to subsequent delay of diagnosis, delay initiation of therapy, and this is lead to potential worse of outcome and death in pulmonary hypertension. Because of that, as mentioned by Dr. Hussam earlier, the early diagnosis, the better outcome. The early diagnosis, the early started treatment. The better diagnosis, as mentioned by Dr. Abdullah, better initiation of therapy and lead to better outcome again. So what is the mindset and pathway in our mind when we see a patient with pulmonary hypertension? Signs, symptoms, do screening test, diagnostic test. We have to stratify our patient at where is your patient exactly at term of severity. Is that at low risk, intermediate risk, or severe pulmonary hypertension that need a specific way of dealing with this kind of cases? So then we start a treatment and we go back, forth and back in terms of treatment in order to make sure our patient in the target low risk, which lead to better survival and decrease the mortality. So we have to keep in our mind that patient with pulmonary hypertension at the time at the level of the time, meaning with the time they get bad in terms of pulmonary vascular resistance, the cardiac output will goes down, and the pulmonary pressure, it can be low or high based on the time, and the symptom will get worse with the time as well. So at this point, we have to understand where is our patient in order to treat them well. So what is the approach of treatment of group 1 pulmonary hypertension? I'm not going to speak about group 2, group 3, or group 4, or group 5. I'm going to specifically targeting group 1 PH. So first of all, we have to understand there is a risk stratification or risk scores. These risk scores, idea of these risk scores is to determine the exact mortality or to push the patient towards the low risk criteria in order to have a good outcome of your patient. A lot of studies, a lot of registries has been done in order to reach what is the criteria that when we apply it in your patient tells you this patient has a good outcome. So either reveal Swedish registry, Compera, or French registration, or French groups risk tools has been applied and try to validate it multiple times to make sure your patient is doing good or bad. So the idea of reaching to low clinical or hemodynamic risk criteria, it goes to the low outcome. When we have a good criteria, or we have low risk criteria, we have a good, better survival and free transplant survival in patients with pulmonary hypertension. So our aim always to reach a low risk group. And even when you see the patient at started treatment, after 3 to 6 months, we have to make sure your patient is still at low risk group. And this is also applied in pulmonary hypertension and shows the better survival if you hit the low risk group criteria. In 2022, also again compare a registry looking into the 3 strata and 4 strata, and when you apply these kind of criteria that we're going to talk about soon, this will lead to better outcome in your patient and better survival as well. So what is the tools that been used in patient with pulmonary arterial hypertension group 1? So we have to apply some certain of criteria when you see the patient at time of diagnosis as well as at time of follow-up. So there is multiple tools has been published in the previous years. One of them is CERS guideline or risk tool or calculator in 2015, or reveal in 2010, something like that. And these criteria based on some either clinical, biochemical, hemodynamic, and 6-minute walk test. So when we see a patient in the clinic at time of diagnosis, we have to apply this kind of criteria. In 2022 guideline, this has been a bit modified, and I will speak in this in details. So when you have a patient with no signs of heart failure, there is no clinical progression of pulmonary hypertension, no syncope, functional class is 1 and 2, has good 6-minute walk test, like more than 440 meters, good parameter of CBET, normal or near normal, let's say normal PMB or pro-PMB, a good criteria of echocardiogram, MRI, cardiac MRI, or hemodynamic and right heart cath. When we approach this kind of criteria in our patient, and our patient at this kind of group in the green group, meaning they have at low risk of mortality in 1 year. And this is our aim and approach in treating pulmonary hypertension groups and pulmonary arterial hypertension. So when you see the patient in high risk group, we have to apply high risk treatment and patient with pulmonary hypertension. And our aim is to push the patient to the other group or to the green side of this table. And why? To decrease the mortality in pulmonary hypertension. The mortality in red zone is more than 20 to 25% in patients with pulmonary hypertension if they stay in this group. Okay, so when we assess your patient in this risk calculator, as I mentioned in the previous slide, we have to assess the patient in terms of treatment. So there are 3 risk stratification, as mentioned earlier. If they are at low or intermediate risk, we have to apply or start with initiate endothelin receptor antagonist plus phosphodiesterase inhibitor therapy. If the patient at high risk, we have to apply 2 medications mentioned, endothelin receptor antagonist, phosphodiesterase 5 inhibitor, and include the prostacyclin therapy, IV or subcutaneous. So at 3 to 6 months of treatment, we have to reassess your patient again to see, does your patient fitting the green, intermediate yellow, or severe, which is red. And after that, we have to apply another, either adding therapy, switching therapy, keep your patient at the same level of therapy, or we have to apply the IV or subcutaneous therapy. At which approach you are starting, you have to reassess your patient and then reapply this risk stratification to its 4 strata as per 22 guidelines. And if the patient at low risk, you have to apply or continue the same therapy. If the patient is still at an intermediate low risk, either to add Selexipag or switching to Resoguat. If the patient at intermediate high or high risk, we have to add IV or subcutaneous therapy, and to indicate and keep in mind the transfer or evaluate for lung transplantation. So after 3 to 6 months, as I mentioned, we have to apply for risk strata, and then we have to go, as I mentioned earlier, to reassess your patient. And what is the idea? Idea to have a better outcome, better survival, decrease the mortality in pulmonary hypertension. A lot of a study has been conducted in the past since 1990, in order to see the effect of the treatment of pulmonary hypertension in these groups. So initially was started as a monotherapy, then started as sequential therapy, meaning adding therapy. And this is the life we have we have more knowledge, and then we apply a combo therapy as a start in pulmonary hypertension. And the idea to have a good outcome. The previous study was looking to a short duration of the treatment, and the recently since 2015 there is after adding or combining therapy, we have applied a longer duration of studies looking to the outcome instead of looking one parameter like 6-minute walk test. Like in an ambition study, adding to therapy decrease the clinical failure by 50% by adding to therapy, ambrisentan plus tadalafil. Ceravan study, adding macitentan reduce the disease progression and hospitalization. So instead of looking to the specific criteria like 6-minute walk test, PMB, and so on, we are looking to the other outcome, which is the progression of the disease hospitalization. So outcome-based criteria. Optimal study looking to 2 medication, macitentan and tadalafil, improve the hemodynamic functioning class and treatment-naive patient. Griffin, selexibag, adding selexibag to the baseline therapy or starting selexibag to the baseline therapy also decrease the clinical deterioration by 40%. Another idea has been published recently, also a switching of phosphodiesterase inhibitor to reissuguat in patients with pulmonary arterial hypertension in the place study, improve the patient 6-minute walk test, PMB, and also the functional class in patients with pulmonary arterial hypertension. What about adding triple therapy? So triple therapy, adding macitentan, tadalafil to selexibag, hasn't shown significantly changes in pulmonary vascular resistance, 6-minute walk test or PMB, but it does show 40% reduction of disease and progression on triple therapy compared to the double therapy. Recently, 1 month ago, sotatercept has been published, which is the phase 3 trial of sotatercept in pulmonary hypertension. Interestingly, this study has been it is a treatment has been added to the baseline of triple therapy. So triple therapy patient, pulmonary hypertension, adding the fourth therapy, which is sotatercept, shows improvement in survival, and also there is improvement in the outcome, meaning 6-minute walk test, and the 8 outcome has been mentioned of the secondary endpoint like PMB, pulmonary vascular resistance, and quality of life. Sorry, it's not the quality of life, the French registry scores and the symptoms. What is the pathophysiology? So let's talk about now about the treatment. So the pathophysiology is there is a balance in our body between the nitric oxide, prostacyclin, and endothelin and thromboxane A2. When there is imbalance between these enzymes and inhibitors, will lead to vasoconstriction, and this will lead to more vascularization and hypertrophy of the vessels and intimal fibrosis. And this will lead to decrease the pulmonary blood flow and sequestration of the bloods, and this will lead to pulmonary hypertension and increased pulmonary pressures, and this subsequently will lead to right heart failure. So the main therapy in our PAH groups is 3 so far, till we have a sotatercept recently. So the main groups is endothelin pathway, nitric oxide pathway, prostacyclin pathway. And all these 3 groups has a specific treatment has been used and shown the effect in the patient with pulmonary hypertension. So when we deal with the endothelin pathway, this will lead to so the endothelin will cause vasoconstriction and proliferation of blood vessels. When we inhibit this pathway, will lead to the opposite effect. The nitric oxide pathway, when we increase the presence of nitric oxide, this will lead to vasodilatation and decrease the proliferation of the blood vessels. So we have to augment this kind of pathway. The prostacyclin pathway, when we augment and increase prostacyclin in the endothelium and smooth vessels, this will lead to vasodilatation and anti-proliferation of the smooth muscles. So we have to increase availability of prostacyclin in our body in patients with pulmonary arterial hypertension. Specifically, when we have L-arginine in the endothelin, this will lead to increased nitric oxide. And when we increase the nitric oxide, we'll increase the cyclic GMB. When we have increased cyclic GMB, this will lead to vasodilatation and decreased proliferation of the therapy. How we do this? By increase the nitric oxide, and this we cannot do it unless we have a nitric oxide in the ICU, or by the limit of the use of phosphodiesterase 5, because phosphodiesterase 5 degrade the cyclic GMB, which is the potent effective component in pulmonary and this pathway. And when we have a cyclic GMB with phosphodiesterase 5, this will lead GMB with no effect of the vessels. So by inhibiting phosphodiesterase by sildenafil-tadalafil, this will increase the cyclic GMB. The other way around, the guanylate cyclase soluble, when we increase or enhance the effect of the molecule, this will lead to increase the cyclic GMB and have the effect. The prostacyclin by the COX inhibitors, by the COX increase the prostacyclin at the level of IB receptors. This will lead to increase the cyclic AMB and to have the effect of vasodilatation and proliferation. The third pathway, which is endothelin, when we have endothelin 1, it will attach to endothelin receptor A and B. When we have these effects, by inhibiting this effect by bosentan or macitentan, this will lead the opposite effect on the endothelin, which is decrease the vasoconstriction, which is meaning vasodilatation, and decrease the proliferation, meaning improve the proliferation by bosentan ambrisentan, or by ambrisentan by effect on the endothelin receptor A. So let's go to talk about the treatment. In the previous days before 1990, they called conventional therapy of treating pulmonary hypertension, giving oxygen, anticoagulation, blocker, diuretics, so on, you can count. And this not lead to any improvement in patient outcome. Then after 1990s, starting the initial therapy of pulmonary hypertension. Initially, they start monotherapy. Then there is idea of double therapy, and there is some ideas in the recent years about the triple therapy I have mentioned earlier. And there's some supportive therapy we are going to talk about in the next slide. The other ideas is to switch some sort of therapies or sequential therapy. Sequential therapy meaning adding therapy in the baseline treatment. The last thing, though, advanced therapy of pulmonary hypertension and lung transplantation. And this is the main treatment and way of doing this in our clinics. So what is the general measurements? Measurement is giving oxygen if needed, diuretics, furosemide, spironolactone. Anticoagulation is not a treatment for pulmonary hypertension like in previous years. However, sometimes we need it for atrial fibrillation, patient with the CTEPH, patient with history of PEs, but it's not essential therapy for pulmonary hypertension. Salt and water restriction is important. Exercise and rehabilitation and important. Avoid pregnancy and contraception because increase mortality by 30 to 40% in patients with pregnant and pulmonary hypertension, and eventually which start pulmonary arterial hypertension. What is the treatment availability in our center? We have all the pathway in our center in the endothelin like bosentan and macitentan. We have a nitric oxide pathway. All these three treatment we have available in the big cities, medical cities in the Riyadh especially. Like sildenafil-tadalafil and rePHer, we have all these therapy as well. We have some limitation of epoprostenol and treprostinil. However, all these medications are available in the big cities, medical city in Riyadh. First time in the guideline in 2022, they mentioned all these therapy. What is the initial dose? What is the maximum dose that you need to reach in order to have the effect of the treatment? All these need to be read later on, but all these medications and the study and approved in treating pulmonary hypertension has been mentioned, and the doses either initially and end. Nitric oxide, as I mentioned, our aim is to increase the cyclic GMB. We have sildenafil and tadalafil. rePHer can affect in the guanylate cyclase stimulator by enhancing the nitric oxide availability and increase the cyclic GMB, or it is by itself, even without presence of nitric oxide, by enhancing the cyclic GMB as well. So endothelin, we have to block the endothelin receptors in order to have the effect of bosentan, ambrisentan, and macitentan. Prostacyclin, when you increase the prostacyclin in our endothelin and smooth muscles, will lead to cyclic AMB and have effect. And there's more detailed receptors and effect of the analogs of prostacyclin or the selective non-prostanoid IB receptor agonist like selexipag, affecting the IB receptor and enhancing the effect and increase the effect of pulmonary therapy. So, and prostacyclin specifically, we have 4 forms available in the market, which is epiprostanol, treprostinil, iloprost, and selexipag. Each one of them has different route of treatment and way of dealing with pre-AH. The epiprostanol, either IV therapy, you need to insert a specific catheter and continuous pump, and using this machine or similar directly to the heart, and it should be continuous use of the therapy 24/7, 52. Also the same apply for treprostinil, either IV or sub-Q, by applying sub-Q materials, and we have a pump continuously used and continuously pushing the treatment all the day and nights and the week, in order to keep the pressure at lower side, and also iloprost using specific device in order to have the therapy through to the lung directly. Selexipag is oral. So the epiprostanol, it is administered through the tunnel, as I mentioned before, cardiovascular catheter. It is have low half-life. It is like a 5 to 6 minute half-life. Specific care and burden need to be taken care, and such medication. There is a risk of rebound of pulmonary hypertension and infection because of the lines. It shows better survival among all patients and pulmonary hypertension specific therapy. Treprostinil can come in at form of a sub-Q and IV, administered through subcutaneous side at the abdomen, thighs, or shoulders. The half-life is better compared to the epiprostanol by 4 hours. It is a lighter burden of care compared to the other. Patient need to deal with all these things on daily basis, to do the mixing, to put machine, to make sure the site is clean, to administer the therapy as well. So we have a lot of contribution of patient care as well. There is significant issue with the pain, can cause significant pain, lead to stop the treatment in some patients. Iloprost, inhaled form or solutions through the mouth into the lung. It need to be administered at 6 to 9 times a day to have the effect, and the half-life is around 20 to 30 minutes. Selexipag, it is less potent compared to the old 3 forms that I mentioned in the prostacyclins. However, can come at tablets, oral administration, 200 microgram first dose, and can reach to 1,600 microgram. There is a lot of improvemements can be shown in this therapy. So prostacyclin is not an easy therapy. You have to make sure the patient has access to advanced care because of the side effect and potency, the half-life, the complication that can be done. We have to make sure the patient physically can apply and do the treatment. They can see, they have a good cognition, and also they have a good mental health. They have a good support at home and environment that can help them when there is a problem because of a lot of complication and the half-life and so on. So again, this is the main approach of treatment of pulmonary hypertension. Our goal is to reach the good outcome by applying this algorithm. So when you have a patient, you risk stratify them, you apply this kind of algorithm at time of diagnosis or at time of follow-up, either by to determine the low intermediate risk or high risk and start the therapy, or after the follow-up, you have to apply the 4 risk strata and apply the therapy as well. There is some sort of patient who has only we can start in monotherapy. I will not go through. There is specific groups that we cannot start combo therapy because of a specific criteria and complication that we need to make sure they start monotherapy and build up. A few slides about calcium channel blocker. You have to understand that a calcium channel blocker is not a treatment of pulmonary arterial hypertension. The calcium channel blocker is not a treatment for pulmonary arterial hypertension unless we have a positive vasoreactivity in right heart cath. If we don't have vasoreactivity positivity in the right heart cath, we should not start calcium channel blocker. A lot of people in the earlier dates, and people still apply these older studies using the calcium channel blocker and pulmonary hypertension. As I said, we shouldn't apply this ideas. We should stop calcium channel blocker if there is no vasoreactivity. So in the patient with idiopathic heritable or drug or toxins, during the right heart cath, we do a vasoreactivity test. If they have more than 10 millimeter mercury in mean pulmonary artery pressure drop at baseline to reach less than 40 millimeter mercury with increase or unchanged cardiac output, meaning there is a positive vasoreactivity, we can start calcium channel blocker and titrate the dose of calcium channel blocker to the higher dose. It's not like a systemic hypertension. It is different approach and different dosing. So we reassess the patient frequently after 3 to 6 months and so on. If we have reached to the low risk criteria, meaning we have to keep and continue your patient in calcium channel blocker. If not, you have to start the 3 pathway as mentioned earlier in pulmonary arterial hypertension. If yes, we have to continue the therapy if they have low risk criteria. So let's have an example. Patient with mean pulmonary artery pressure at time of right heart cath is 45. We have to drop the blood pressure to have a positive pulmonary hypertension criteria and calcium channel blocker, drop by less than 10 millimeter mercury to 35. This is positive calcium channel blocker responder. So mean pulmonary pressure 45 minus 9, so it's less than 9, less than 10. This is not a calcium channel blocker responder, or vasoreactivity is not a positive. Mean pulmonary pressure 55 at the start and decrease by 10 to reach to 45. This is not a vasoreactivity positive. It's not a positive. So we should not start calcium channel blocker. The only one is here, the first one. So what is the treatment? Mainly is nifedipine, diltiazem, or amlodipine. You can see you have to reach to maximum dose to reach the maximum effect. So it's not nifedipine like other patients with systemic hypertension, 30 milligram. We have to reach to 120 to sometimes 240 milligram a day. Diltiazem as well, amlodipine as well. It's not 5 milligram. We have to reach to 20 milligram. So it's advisable to start like smaller dose and build up the treatment, all these 3 one by one. We are not choosing all of them. We are choosing one of them to start with a small dose and build up to reach the maximum effective dose as mentioned previously. And what does it mean of adequate response? We have low risk WHO function class, hemodynamic improvement, and no need for, if not fit, we have to add PAH target therapy as mentioned before. So after these groups, after starting all these algorithms, if there's no improvement or reaching to the high risk group, we have to keep in our mind, we have to evaluate for lung transplantation. And this is the kind of evaluation when we have to refer patient to transplant. A lot of drugs, a lot of therapy, a lot of idea in the pipelines, looking for how we can improve the patient outcome, improve the proliferation in pulmonary hypertension. One of them is sotatercept. It is a lot of money need to be spent in patients with pulmonary hypertension. A lot of things is psychological, spiritual, palliative, social support. It's not just a treatment. A lot of things is going on in order to deal with pulmonary hypertension. It's not one-man show. So this is in summary. Oxygen, diuretics, salts, supervised exercise and rehab is important in patients with pulmonary hypertension. Anticoagulation is not a treatment for pulmonary hypertension unless indicated for other reason. Calcium channel blocker is not a part of PEH targeted therapy. You shouldn't start it unless we have positive vasoreactivity test. Avoid pregnancy and contraception because it can lead to high risk mortality. PEH targeted therapy, mono, combo, triple therapy, switching therapy, adding therapy, we have to apply based on the algorithm, as I mentioned earlier. The idea is, what is the treatment? The idea is how to apply this kind of treatment. It's not just a start one therapy and leave it. No, we have how to apply this therapy in order to have the good outcome. Regular comprehensive assessment of patients with pulmonary hypertension is required to check your response. Otherwise, how you can know that your patient is doing good or bad? They have good outcome or not. We have to assess and apply specific criteria. Better risk stratification, better outcome. Thank you so much.
Thank you, Dr. Shaya. Do you want to introduce Dr. Omar Tamimi?
Yeah, just give me a second. So now I'd like to introduce Dr. Omar Tamimi. Dr. Omar Tamimi He is a consultant pediatric cardiology. Dr. Umar is interventionist and interested in pulmonary hypertension and congenital heart disease in our center in King Fahad Medical City. So, Dr. Umar, the floor.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Shai. Thank you, Dr. Abdullah and Dr. Hassam, for this nice meeting this afternoon and Friday of Ramadan. Thank you for organizing committee, and thank you for all the attendees who's coming to hear from us about the pulmonary hypertension. So my task will be inshallah short, so we can finish earlier. So I give you some case study, and we started with 3 cases of different etiologies. Most of them is from different ages, and most of them is a patient with pre-capillary. All of them is pre-capillary, and we'll go by step of hemodynamics to know about this. So keep eye with me, and we'll move slowly. This is a patient with case 1 and case 2 and case 3. You see them. And we do a right heart cath, and the right heart cath in the case 1 is PA pressure of 35. So the PA pressure by definition is pulmonary hypertension. The wedge pressure is 10. The RA pressure is 8. So this is going with the definition of the pulmonary hypertension. The PA pressure is more than 20. In the case 2, the same thing is we have 55 PA pressures. The wedge pressure is 11. RA is 7. So it's the same going with this case. The third case is having a PA pressure of 30. I'm talking about mean PA pressures. The wedge pressure of 13, and the aorta is there. So this is 3 cases, and if you see them, all of them is pre-capillary pulmonary hypertension because the wedge pressure is less than 15, and the mean PA pressure more than 20. So from this information, you cannot differentiate about these 3 cases. Now we'll go more. We get an oxygen saturations. The mixed venous pressure saturation in the first case is 63, BA is 64, so there is no difference. The systemic saturation is 96, so there is no left to right or right to left shunting in this case. In the case 2 is there is the mixed venous and BA pressure saturation is 65, and the same thing with aorta, it's 96. So there is no stepping up. So this is giving you there is no shunt in this. In case 3 is that this is a patient who has mixed venous of 63 and BA of 85. The systemic saturation is normal. So it's this patient have a stepping up of the between the mixed venous and BA pressure. So it's telling you this case is different from case 1 and case 2. There is a shunting from the left to right. When we go to do a calculations in that setting that the QB, which is the QBI, index pulmonary flow, it is 3 liters, which is normal. And QS is 3 liters per minute per meter square, which is normal. QBQS is 1. PVRI is 8 wood unit per meter square, and SVRI is 18. So this is the patient who has high pulmonary vascular resistance, which is more than 3 for children and more than 2 for adult. So, and the QB is within normal. There is no shunt. In the second case, if you go there is the index flow is high, but the QB case is 1, BVR is 8, and SVR is 11. So still this patient who has no shunt, the pulmonary vascular resistance is high, the flow is good, and this patient has still the pulmonary hypertension. In third cases, there is a difference between pulmonary flow and systemic flow. The pulmonary flow is 2.8 times of the systemic flow, and this is going with a patient who has a shunt and congenital shunt most of the time. And this patient is having a pulmonary vascular resistance is 1.2 only. So this is the three cases. You can now feel that there is 1 and 2 is more or less they're the same, but the 3 is a patient with a shunt. We do a vasoreactivity and the vasoreactivity, which is mentioned earlier by Dr. Shaya. The vasoreactivity, there is 2 types of vasoreactivity test. One vasoreactivity for congenital heart diseases with shunt, and the other one is vasoreactivity for uses of calcium channel blockers. And this is the vasoreactivity for uses of pulmonary calcium channel blocker is indicated in idiopathic, heritable, and drug-induced. This is the 3 indications. So that this 3 patient who has indication to do vasoreactivity. In congenital heart diseases, the vasoreactivity is not to use the calcium channel blocker, is to operate or not to operate. So this is 2 types of vasoreactivity between the difference between the patient in group 1, which is a patient with idiopathic or heritable or drug-induced. The case in the 3 is a vasoreactivity was done because of the patient is going for surgery. Now, what I'm seeing that in the nitric oxide, the first cases in the baseline was the BA pressure is 35 after nitric oxide 20 parts per million for 7 minutes to 10 minutes. The BA pressure dropped to 33, which doesn't change. So there is only drop in 2 millimeter mercuries. In case 2, the BA pressure was 55 and dropped to 35. Which pressure doesn't change. The blood pressure doesn't change. In the case 3, the BA pressure was going up instead of going down, and the BA which pressure doesn't change much. So that's the different indication for vasoreactivity. If we look for the oxygen saturations in the first cases, after nitric oxide mixed is 63, BA is 64, doesn't change much from the baseline. The second one is 70 and 75, which is improved from 65 to 70. The saturation doesn't change. And the other patient is the patient with shunt. The mixed venous is coming down, BA is increasing, and this is increased with the calculations. If we go to calculation, the first patient calculation was 3, the QB/QS after nitric oxide. The QB and QS is 3, and there is no shunt. The rePHer is 7.5. The second case, that the QB is 6.5. The QS is 6.5. There is no shunt, and the rePHer has come down to 3.9. The third case is that the patient with shunt, the shunt is getting more worse, and the QB/QS is more than 3 to 1, and the pulmonary vascular resistance drop less than 1. So when we go to look for the differences in the calculations, you will find there is the calculation, the baseline, and the pre and post. The pre, and this is the post. The first case doesn't change much with the nitric oxide, doesn't change in the BA pressure, doesn't change in the flow, and the resistance almost the same, 7.5 and 8. In the second case, you see that the 6.5 and 6.5, which was before, is 5.4, which is increasing the cardiac output instead of decreasing it. This is very important. And increasing in the cardiac output, the pulmonary vascular resistance drop. The same in the third case was the congenital heart, which is showing a major reduction in the pulmonary vascular resistance and increase in the shunt. So this is 3 cases. In the case 3 is easy to know there is a shunt, but in the case 1 and 2, there are difference in their vasoreactivity. So what I'm mentioning now, although initially I told you 3 cases in different ages. The first case was 2 years old. patient with family history of pulmonary arterial hypertension. One sibling died at the age of 14. This is the hemodynamics. If you look for that, hemodynamics doesn't change, doesn't make difference from the other patient who is 40 years old with exercise intolerance and easy fatigability. Echo showing that the RA and RV, estimated RV systolic pressure more than 70. That is the other one. The third case is 27 years old with ASD secundum and RSV is 50. So if you see that the initial assessment and the ages, you cannot know from the hemodynamic, you cannot make guessing of what age. But when you see that the data you collected from the previous, that this make the difference. The two years old patient and the 42 years old, almost they have the same hemodynamics data, whereas the 27 years old, if I have a fourth case of a pediatric, they will have the same hemodynamics with the congenital heart diseases. So vasoreactivity in the first cases was not vasoreactive, and the definition of vasoreactivity in the cases is the drop of mean PA pressure less than 40 and the decreases by 10, and there is no change or increase in the cardiac output. So if you go for case one, it was below, from the start below the 40, but the drop only is in 2 millimeter mercuries, and the cardiac output doesn't change. So this is an non-vasoreactive patient. The second cases is there is a drop in the PA pressures, which is more significant, and there's increase in the cardiac output. So this patient can be labeled as a vasoreactive patient. The third patient is a congenital heart diseases, which have significant increase in the shunt dropping in the vascular resistance. Although from the baseline data, this patient operable, vasoreactivity also vasoreactive. This is the three cases. From this three cases hemodynamic scenarios, you can know what you are doing for. The case one has to go for advanced BH therapy, which is Dr. Shaya mentioned. Although she is a pediatrics, but we can use all the medication in the 3 lines with them in their different doses and different indications. But in the same thing with patient with pediatric pulmonary hypertension, we can use nitric oxide pathway, we can use endothelium pathways, we can use the prostacyclin pathway. The prognosis in pediatrics, if not treated, is very poor, and if you compare it to the adult. The second case is the patient who is vasoreactive. You can start calcium channel blocker with high doses, as Dr. Shaya mentioned, and you should keep eye on this patient because some of them, they become non-vasoreactive with time, and you should be careful to assist them in the periods. If they become less reactive, then you have to change to advanced therapy. The third case is very easy cases. It's a congenital heart diseases, and we go for device or surgical closures. So this is by the end. Thank you very much for you and for all the committee and all the members. Thank you very much.
Thank you, Dr. Omar, so much. Very interesting approach. We are almost finished, but we will give a few minutes to answer questions. If I can ask Dr. Shaya, Dr. Abdullah to join us in the discussion. We have received a few questions from the chat, and we will try to answer them now. Dr. Abdullah, there were plenty of questions asking about the echo. When you do an echo, and they notice that there is a mild elevation in the pulmonary arterial pressure by an echo estimates. Everything else is normal. What should they do?
Yes, so I think it has to do with who's the patient in front of you. Do they have any risk factors for pulmonary hypertension or not? And then based on that, the guidelines clearly tell us what to do in those settings. The other thing is you need to look at other signs of pulmonary hypertension other than the RVSP. So does the RV, is the RV hypertrophied? Is there any RV dilatation or RA dilatation? Things like that will help us to know what's the best method, what's the best next step. But in general, I would recommend if there is no obvious reason, to refer those patients to a specialized pulmonary hypertension center. Thank you.
Okay. Thank you, Abdullah. Shaya, there is a couple of questions about the process of referral. How can they refer to us? Will you please explore this part?
Okay, thank you, Dr. Hassam. Thank you for the attendees. So there is multiple way of referral. The one official and known to everybody in the kingdom is the system called IHALATI system. So anyone in the other hospital outside the cluster 2, they can send a referral with some few information about the patient and indicating the pulmonary hypertension. It's important to mention that like echocardiogram, some important information to apply to justify the referral, and send it through IHALATI system. It will go through the system, and then eventually you're supposed to go to the centers where there is pulmonary hypertension. One of the important thing is to have like the IHALATI number, and we are more than happy to receive it through emails or contact us or send anyone just told us that number is this, and we can build it up from the system and from the pool and bring it quickly to us, because sometimes there is missing information from IHALATI. So through IHALATI system, you can just send the referral and we can accept it within a 1 or 2 week. We can see the patient and do the important workup. The other way is just contact us. Give us your opinion and send us either email or through the phone, and we can guide you to how we can see the patient and refer to us and open the file and continue management of pulmonary hypertension. These two important methods, at least this is currently the easiest way of referring to the C2 or cluster 2 centers in pulmonary hypertension.
Yeah, I would add to that, even the non-Saudi or ineligible patients in our center, if they are ill enough and they are admitted to a hospital and you feel like you are going to send them to us, we always look into this. It's not like going to completely reject. If there is a potential that we can help the patient, we are here first and beyond. Alhamdulillah, the resources are available and our leadership is supportive of this as well. If we can serve a human being in need, we will be very happy to do it. Maybe the system is not very open, yet we did bring people who are non-eligible before as a life-threatening, and we managed to get them through the system. So again, we are here for consultation. You can always call us if you're caring for the patient outside, or if they are eligible, just send the referral and we'll take care of them. A couple of questions about the true prognosis of the patients, different questions, different settings. Yes, the patients do die. We do have patients who come to the ICU and die from progression of their disease, but at the same time, this is not a very frequent happening. The medications available that went through are somewhat effective. We have patients who have been following for more than 15 years now in the clinic, and they are still doing okay. We have patients who had milder diseases, improvement with treatment. A couple of cases, they became pregnant, very specific, strict criteria, but they did make babies, and alhamdulillah, they are going through. We have a few patients who had lung transplant done within the kingdom and outside the kingdom. So overall, yes, we see all the spectrum of the disease. And alhamdulillah, we think we are doing better than the surrounding countries in this regard. Saudi Arabia is considered advanced in terms of pulmonary hypertension. It is a multi-specialty disease. You need good cardiologists, pulmonologists, intensivists, surgeons, radiologists, diagnostic workup, and a good system where we can provide them with expensive medications. Alhamdulillah, al-khair mawjood, and these patients are never suffering from lack of resources or medications. So again, we are proud of the milestones that we crossed in pulmonary hypertension in the kingdom. We will continue our journey to see how we can help the patients. But our message today is, please think of PH. If you really think your patient has PH, you wanted to do a little bit of workup, we encourage you to. This is part of the fun that we do with the practicing medicine. But if you feel like you don't have resources and we can help in any way in the clinics, in the hospital, do refer. And the whole program actually was intended for this referral process, whether refer for consultation, exchange knowledge, or refer for taking over a care of a patient who's in need. I would like to thank Janssen again for the sponsor for this. I would like to thank the organizers for providing the platform, and of course our dear speakers who had done a great job in presenting their presentations. And the thank is extended to you as audience, and hopefully we did contribute a little bit benefits for you taking some of your precious Friday afternoon time during Ramadan. رمضان مبارك على الجميع، وكل عام وأنتم بخير، مبارك عليهم العشر الأواخر، وإن شاء الله نشوفكم في another activity soon. السلام عليكم.
وعليكم السلام.
السلام عليكم.
شكرا، يعطيكم العافية. السلام.